Good morning, good afternoon, good evening, friends, depending upon which part of the country you are joining us from. So we welcome you from CAHO, the Consortium of Accredited Healthcare Organization. Friends, you know that this organization, which is a not-for-profit body of healthcare institutions, diagnostic centers, and quality professionals, is one of the very unique organizations which is working towards promoting patient safety and quality, not by just promoting accreditation, but also by promoting the whole culture of safety. And towards that, this particular series of webinars that we do with ISQua is a great testament to the collaboration that CAHO has been able to achieve with various bodies. And this particular one is of very special importance to all of us and to everybody across the globe now. So this is now the 46th webinar that we are presenting today to you. And to take this forward, I'll request Dr. Lalu Joseph, our Secretary General, and the, of course, Superintendent at the CMC Vellore to take this forward. Over to you, Lalu.
Very good evening, and thank you very much for joining today's session, the 46th International Webinar Series. It's my proud privilege to welcome all of you and also to introduce the moderator for this evening. We have a very good session lined for us, and this session is going to be moderated by none other than Dr. Atul Kapoor, the Managing Director of Regency Hospitals, Kanpur. Dr. Kapoor is the promoter and Managing Director of Regency Hospital Limited, a highly qualified surgeon. He holds a master's in surgery from GSBM Medical College, Kanpur. Dr. Kapoor consistently excelled academically, achieving commendable positions during his undergraduation. Recognizing the dearth of quality medical facilities in Kanpur, he established the first Regency Hospital in 1993. Today, the group has expanded to 6 hospitals and continues to grow. Beyond his surgical expertise, Dr. Kapoor's leadership is crucial in guiding and empowering Regency Hospital Limited's core team. His dedication and strategic vision drives the company forward, delivering exceptional healthcare and achieving organizational goals. Regency Hospital is UP's largest group of chain hospitals operating in Uttar Pradesh. It currently manages 750 beds across 6 facilities in Kanpur and Lucknow. Regency is in the process of expanding to 2,400 beds across 10 facilities across UP. He is a member of the core committee of CAHO, and we are extremely delighted to welcome him to moderate this session and take this session forward. Over to you, Atul, sir.
Good morning, everybody, and thank you so much, Dr. Vijay and Dr. Lalu. And I welcome Trevor for this webinar at today. Well, enterprise risk management in healthcare is a big subject, you know. It's not, you can't speak anything in 1 hour, but still, to summarize, basically it's a set of clinical and administrative procedures, processes that were, and the reporting structure were designed to basically detect, monitor, and, basically assess, mitigate, and prevent risk to the patients. That is the basic idea of enterprise risk management in healthcare. Now, this is a larger term, but again, when you go deeper into the matter, you require a lot of, inputs from various departments of the hospital, which includes your HR, your training, your processes, your communication, lots of things, which make the, mitigates the risk to the patients. That is the ultimate aim of any healthcare facility. So without taking much time, I'll request Trevor to come up with his address. Then after that, we can all discuss whatever our issues are. Thank you.
Wonderful. Thank you. Thank you so much. I'm so happy to be here today. Again, thank you to CAHO. Thank you to Dr. Agarwal, Dr. Joseph. Dr. Kapoor, that was a great introduction. You're right. Integrated risk management or enterprise risk management is absolutely a challenging subject, one that is complex and that to do within 40 minutes can be a bit daunting. So I will try to cover this in the most practical sense possible, sharing and having a conversation with you. You have my bio. I'm Trevor Hall. I'm very much a practical individual. I was a past firefighter. I've spent many years in hospital doing risk management. management. I am a nurse. I have a Master of Science. I am a Fellow of Biosecurity and Quality Improvement, as well as I'm pursuing a PhD in Systems Engineering at the University of Toronto, specifically in this area. So I'm very happy to be here today. It's about 5:30 in the morning where I am, and I'm joining you from Calgary, Alberta in Canada. And yesterday was a very special and important day. It was our National Day for Truth and Reconciliation. And I would like to acknowledge and take this opportunity to share that I'm on the traditional territories of the people of Treaty 7 region in southern Alberta. The city of Calgary is also home to the Métis Nation of Alberta, District 5 and 6, and I'd welcome any of your acknowledgements of where you're joining from today in the chat. So again, I have no disclosures for today's talk, and again, I just wanted to say thank you and make sure that you know that this will be a very practical conversation and one that I'm hoping to approach from a systems lens. A few things that you'll get out of this today, as Dr. Kapoor mentioned, this is a very large topic, and I hope you'll take away a few maybe new thoughts that you may not have thought around enterprise or integrated risk management. One that is the interconnection and the systems of how it's all going together, as well as how can we learn from harm, and really CAHO's message around this importance around safety and risk management action. Very quickly, just to give you a sense of where I'm from, I'm the Vice President of Risk and Safety at something called the Healthcare Insurance Reciprocal of Canada. This also is a not-for-profit, and we're a leading medical malpractice insurer in Canada. The really cool piece of why I want to be here is that we are safety, we are risk, and we get to support the front line coast to coast within Canada. So very, very happy to be here. This is the insurance landscape. So you can see we are coast to coast, and I'll make sure that I circle back from some of these practical learnings. For this talk today, I want to stay away from definitions, and for the talk, enterprise to me will mean integrated, and you'll hear me talk about integrated risk management, and that'll be synonymous around enterprise risk management. Boy, today we're going to really talk about the effects of uncertainty. So when you think about integrated or enterprise risk management, really, I want you to focus on uncertainty. You are experts in this. You are clinicians. You are administrators. You are innovators. The concept of the effect of uncertainty, this is what we manage. And I'll walk through some of these examples of why this is so important to understand and be okay with uncertainty. If you get nothing out of this presentation today, you may think about what ifs, what if this, what if that, and how do you mitigate that? So again, the effect of that uncertainty. One thing that we may not always hear within traditional enterprise or integrated risk management is the concept of interconnection. And I'll go into this, but I'm hoping you'll be able to take that point of difference away today, is that things are connected and things are linked, and it's not always the cause and effect that we'll be able to speak to. Okay, so to start us off on our journey of the effect of uncertainty, I wanted to kind of get an idea of how do we approach risks in our own lives. So how do we go about determining what we eat or what we consume? Would you be surprised? I don't think you would be. The Global Death Index would say about 1 in 6 in 2022 would die from heart disease. So the choice is directly made of what we decide to eat. Or how about what we consume? Or around 1 in 55 will die from opioid-related deaths in 2022. In Canada, it's even worse. In 2023, we can see that the toxicity deaths around opioids are absolutely alarming. It's an epidemic. 22 deaths on average per day. Think about that from a basic sense. How do we engage? How do we go about each day? How do we determine what we do and what we don't do? How about your own risk tolerance in your own lives or in your family lives? This is a smoke or carbon monoxide detector. Do we have them? Do we use them? Do we replace the batteries? Each year in Canada, we continue to have deaths from fires. Globally, 1 in 1,000 will die from a fire in 2022. We know fire is dangerous. We know smoke is alarmist. And how do we prevent that, and how do we go forward? If you do anything today, if you do have detectors in your home, spend a few minutes checking to make sure they're active. Or how about the activities in which we go about? Does anybody like to do hiking, to go for walking? I'm a huge sign nerd, and these are some of the signs that I found over the summer. What do signs mean to you in your daily lives? So if I'm hiking, this one is in Nova Scotia to my left, and you see a sign that shows a person falling down some rocks and is calling for attention. Clearly there's risks here, right? And how do we determine what we're going to do? Do we go? Do we not go? Do we stay? How about the one here to my right, which was in Switzerland, really saying, hey, holy smokes, you're now entering where there's inherent hazards. You're on top of the mountain. This was on the Schlitthorn on top, and the choice that we made to go out and walk that. How do we determine the effects of uncertainty? What are we doing, and how are we comfortable with this? Beautiful Lake Brienz in Switzerland, walking along this lovely lake, the serene wind in your air. Would you say that we know everything in life? Do we know all the risk that is around us? After getting home from our walk, I saw this article that tweaked my mind. So during the war, all of the munitions, some of the munitions from the war are now stored within this lake. And there is a call for action of how do you actually qualify these munitions. So the idea of unknown unknowns, how would you know walking along a beautiful lake that you are also walking on hundreds of thousands of piles of munitions? You don't. So the concept of what do we know, how do we engage, the effect of uncertainty, and really, as clinicians, as risk managers, as administrators, what are those unknowns, and how do you manage those? Dr. Kapoor started to talk about how do we go about managing risk, and how do we think about this very large, complex topic. There are many processes around enterprise or integrated risk management, and all are great. A few things or commonalities or points of parities that you may see throughout these are a few of these distilled down. So the attention to the identification of risk, so identifying. The assessment or the degree of that risk, so identifying, assessing. And how do you prevent, transfer, or reduce that risk? Some of that reducing or preventing or transferring risk is done through financing risk, and that's through insurance or reinsurance. And sometimes we don't always think about these things within our toolbox. So as a clinician, as a systems minded person, as a risk manager, I have multiple toolkits or toolboxes that I can think of that I can pull from. And if you look at these components of risks, these are a few things that you'll probably see in your practical everyday. So we may say, okay, great. So we've talked about a little bit about unknown unknowns, the effect of uncertainty. Great, I have to identify, I have to assess that risk. I have to go and I'm going to try to reduce or prevent or transfer that risk. What kind of risks may I arise? We know these aren't unknowns. These are where risks will arise within your practice, within your organization, within your systems. We have intentional pieces, so such as battery or assault. We have negligence. We're in the business of care. We know that we have these duties. We have breaches happen. We have pieces of organizations where we may contribute to those negligence, or is it from our staff that are working with us, or is it from the institution itself? I'm not going to spend too much time on this, but more so for you to take away thinking that we know where risks come from most of the times. Do you think, so if we were together in the same room, I would go into a bit more detail around practically where is the assessment risk coming from? And through that discussion, we may get to the point where we're saying, you know what, determining what to do, is it riskier, or is the doing part the riskier? So is it deciding what to do, creating the plan and the action, or is it the doing? And for our conversation today, there's risk within both, but it's largely that doing, that acting, that intentional piece of where we may see more risk. I wanted to quantify it just a bit for our conversation today, what I see across coast to coast. So looking at my claims data, or looking at our healthcare experience, I can tell you we're in the business of care. And you wouldn't be surprised that our professional liability, or that doing, is 78% of all our claims. Next is around that idea of bodily injury, or that injury happening, which was about 13%. So things happen, right? The decision making, the processes, the considerations around that is a very small piece of that. So in Canada, I'll speak to the Canadian context from what we can see, is the decisions from our governors, our leaders. There's very limited liability that is taken through that action. So what I'm speaking is not to say that it doesn't happen, but more so to say around thinking about, when you're thinking about integrated risk management, the doing part absolutely has greater risk attached to it. And I want for you today to think around that effective uncertainty and that interconnection around that doing. Are there ways that we may be able to reduce, transfer, or prevent that risk? Each year through our organization, we look across what are people talking about. So on the previous slide here, this is actual, this happened, this is what we're seeing. What you're looking at here is, what are people talking about in Canada? So leaders such as yourselves, what are we talking about? Over the 5 years, we have something called the Risk Register. This is way more before 5 years, but the last 5 years trend here. What are boardrooms and senior leaders talking about? And what you can see here is, over these 5 years, a few things come to mind. Again, we're in the business of care. So when you hear people talk about enterprise risk management or integrated risk management, potentially for a for-profit company or non-health related company, absolutely complex. But when you're looking at it from a healthcare perspective, absolutely complex. And the reason being is, we're in the business of care. We should see that people are talking about care, our processes, as Dr. Kapoor were talking about. How do we deliver that safe care? Over the past few years, no doubt, thank you for being our front line. The global pandemic, absolutely. Healthcare human resources, this is a time around how do we go about ensuring that we have the right people caring at the right time and at the right place. We also know that healthcare human resources is a very scarce resource. When I, as a clinician, leave the system, I'm taking my experiences with me. How do we make sure those experiences remain within the systems? How are we training new clinicians and leaders? How are we making sure that there's the supports? And no doubt we can see that information and management technology are absolutely conversations within boardrooms and leadership tables. So again, the previous slide was what we saw from a medical legal context of what actually is occurring. And what we can see here is what people are talking about. So if you hold some of these topics in your minds as we kind of go through the next things, I want to make sure very, very clear that we're on the same stage around that doing or that action. And I know that we are. So very quickly, before I go to that, I don't see too many people. I see a few, so I'll walk through this myself. But if we were in the room together, I would say on this side of the room this hand here is very safe. This hand here is very dangerous. If my nose is the industry of healthcare, which way should I go? Should I go to very safe, or should I go to very dangerous? If we had the chance to be together and we were giving virtual and arm bumps, high fives, the conversation may say, you know what, some thinks it's very safe, some may think it's very dangerous. Where we can land is, we know, as Dr. Kapoor was saying, is that absolutely it's complex, and the industry of healthcare, as we know, can be very dangerous. I can see some of you, so I'll ask this question. Please raise your hand. Please raise your hand if you've ever made a mistake in your life. Yeah, there's some, yeah, right? Just keep your hand up if you made a mistake this morning. I did, yeah, awesome. Or this evening, wherever it be, right? So to err is human, humans make a mistake. Okay, raise your hand again if you like to talk about your errors. Not really, right? Yeah, so there's some of us do. Yeah, right?
Yes,
Right? Yeah, absolutely. Thank you so much for speaking about your errors. Not all of us, we don't like to talk about it, right? It's not human nature to say, yay, I did this, right? It's really, we have to get there. So if we put those things together, so one, we work in a really dangerous industry. Two, the majority of us make mistakes, right? We're not humanoid robots. We're human, we make mistakes. And three is, we don't generally like to talk about our errors. So that is the preposition for safety. That's the preposition for integrated risk management. So I won't go too deep into this because I know that there's been other webinars around this, but this speaks to the inherent complexity in danger of healthcare, excuse me. We also know, again, from these pivotal reports over 2 decades ago around that there is a call for safety. And 3, if you haven't read this paper is quite interesting by Amy Edmondson that really talks about that paradox that I just mentioned around we make mistakes, but we always don't like to talk about it. And there is that paradox. And how do we move to that just culture? Okay, so we very much know that there's this need, this lack of patient safety globally still remains a leading cause of preventable death. So again, we go back to even our data around how do we make decisions. We know that what influences the outcomes are largely still unknown, and there's really no exact formula of how to design system safety. So this is why we need that call for action. So I wanted to spend a little bit of time, and just aware of my time here, to talk about how do you design safety in a system? How do we go about it? Can you design safety in a system? What you may be aware of and what you're looking at here is a very traditional approach to enterprise or integrated risk management. Sometimes people call it the risk management bow tie. What you have on the one side is the causes, and what you have on the other side is the consequences, the likelihood, the impact. How do you prevent? How do you mitigate? How do you transfer? A key piece of this tool, and again, all tools are good for our toolbox, is around cause and effect. So this caused this, or has anyone done a decision fault tree before, or have you looked at the fishbone diagrams in your past webinars? So again, this incident was caused by this factor or these contributing factors. Where I want to expand our minds, and I know you likely are experts in this already, but let's try to do another kind of poll here. So raise your hand if you do you drive? Do you drive a car? Any people driving cars in the audience here? Maybe perhaps a few. Okay, great. Who raise your hand if you drive the speed limit? Anybody drive right at the speed limit? Yeah. Okay, cool. Keep your hand up or raise your hand if you go 10 units of driving over. Any people go 10 units over? I see maybe 1 or 2. How about 20? How about 30? 40? Yeah, you might be late, right? 50? 60? I don't think so, right? 70, 80, 90, 100. It's common, right? So it's common that we have a posted speed limit, a legislated speed limit, but it's common for us as a society to go over, right? So that norm, that cultural norm. So if we're looking at this, Rasmussen, again, a really great paper around safety dynamics and risk management. I think what we can take away from this, really using the driving example, is that we have these error margins that we feel comfortable that are within. Think about your clinical or your leadership practice. What do we know within our clinical practice is like a social norm? So potentially with pharmacological induction or augmentation of labor, do I feel comfortable to infuse synthetic hormone, oxytocin? How often do I use it? When do I use it? It's a high-risk medication, has lots of complications, but do I feel comfortable using it? So these examples, if you go back to the driving example, is that there is what we know and what we can do, and then we have what should we do, and there's a piece of tension around that based on societal norms. The next piece, still within this great paper, again, if you have a moment or if you're looking to read something over dinner, is around healthcare is a complex socio-technical system. It's potentially not this idea, or it's not this idea that this caused this. There's many reasons of why things can occur, and it's a living system. It's dynamic. What this shows you here, even for the driving example, is that hey, potentially within different parts of the world, governments set limits. They're regulated by certain judicial authorities. And how do we operate within them? And what's our norm? What do we feel safe going? Is it 10, 20, 30, 40 over? Is it under? Our pieces around risk. So if you take away anything around this, think about that culture. It's a flow. It's dynamic, and also think about how healthcare is a complex socio-technical system. It's not this in this. It's around how do we interact? How do we interconnect together? I like this definition very much, and a piece that we may not always think about with integrated risk management or enterprise risk management is the idea of systems and system thinkings. Complex systems cannot be understood by the study of the parts in isolation. The very essence of the system is the interaction between its parts and the behavior that emerges from those interactions. We must analyze the system as a whole. So think about this. We must see the system as a whole, and the system have systems within them. And how do we make sure that we're understanding that? I won't go too deep into this just because of the time today. And again, as Dr. Kapoor was mentioning, enterprise and integrated risk management absolutely it has thesis dissertations on this. We could talk for hours or days and years on this. A few theories for consideration today that you may not have seen before, or you may be experts in them, is around different frameworks of how do we understand dynamics within our systems. So as examples, the Systems Engineering Initiative for Patient Safety, or SEEPS, is something that is really important to understand. Functional resonance analysis method is another understanding that seeks to understand adaptability within the system. And one that I enjoy beyond SEEPS is the idea of the systems theoretic accident model and processes, or STAMP. And the idea of thinking about safety design and how do you achieve safety design for optimal outcomes. Okay, so again, we started off with the concept around uncertainty, challenging the motion around the idea around interconnectedness. We work in a very complex system of socio-technical nature. Because we work in healthcare, it's even more complex. It's the idea of how do we learn from harm, or can we learn from harm? So I want you to think about it just a little bit here, and please indulge me for a few minutes around this. What you're looking at here is a bobcat, right? So something that digs hole. The whole purpose of this is to dig hole. Inside of that is a sign. Again, I'm a huge sign nerd. I love signs. What is this communicating to you? So it shows you this the boom, or the digging tool, smoking this thick person's head open, right? So what the sign is telling you to avoid death. So if we work this through from a linear fashion, so if you get into this machine, you leave the boom up and the boom hits you in the head and you die, I told you to avoid death. It's not my problem. It's your problem because you died. Okay, so think about that. I told you not to die. You died. Not my fault. Your fault. Okay. Where do we see this and can we see this in other places? So we see this a lot in academics or in healthcare. Have you ever heard, I gave you a policy and procedure, you didn't follow that policy and procedure, therefore it's your fault, not mine? Or how about, I gave you this training and education, you didn't follow that training and education, not my problem, your problem. Okay, so this whole idea around blame and shame. So this is a sign that I like a lot. It's at a school near my house. Playground rules. We all have played on a playground. One, keep your hands and your feet to yourself. Okay, that makes pretty good sense, right? Good rule over life. Two, walk, don't run. Okay, I'm not sure too many kids that are not running in the playground, but I can get on board with that. No pushing or shoving. Okay, good. But how about this one? Think before you act. Think before you act. The question I'll pose to you is thinking enough? Okay, so again, I like hiking, very poetic kind of sign here. Again, I like signs. In the middle of the forest on what we're going to go hike, it says to go or not to go. Again, decisions. How are we making decisions? or to do or not to do. Should I do this? Should I not do it? And again, there's that sign I showed you earlier. Is clearly potentially there's risk here. Potentially someone has been harmed in the past. How do I make my decisions, or what are those decision makings that I decide to go about doing around risk, the effects of uncertainty? This is my office building if you ever come visit me. I also love doors. If we were in person, I would ask you, can you please tell me, do I push or pull for these doors? And we would have a conversation. Largely would net out is we don't know, right? You can't tell from this picture if it's a push or a pull. There's no signifier to the individual telling you. Equally challenging within these doors is the top part, the green. So does that mean green is a go for the security alarm is on, or green to exit the doors? A lot of times in my building, you'll notice people face planting against the door, as you would assume that green means good. I can walk out. Actually, green means security system's on and you can't proceed. So how do we interpret the worlds in which we live in, and how do we make these decisions? You might say, okay, great, Trevor, we've talked a lot about integrated risk management. I understand that I need to assess and identify, prevent, transfer, and mitigate these risks. We walked around how as humans we make mistakes and we don't like to talk about them, and we work in a dangerous industry. And really that there's this interconnectedness around risk. We work in a very complex socio-technical system, and how do we design systems? So why are you showing me this Droop effect or this Droop test? And how does that design impact? So in the room again, please do this with your colleagues beside you, or if you're in your room yourself, please list it out. But just, we are hardwired as humans. Humans make mistakes, and how are we hardwired? How we are hardwired really impacts how we design safety for the systems. So if you can, for me to make sure you're awake, please read out the word. So yellow, blue, orange, black, red, green, purple, yellow, red, orange, green, black, blue, red, purple, green, blue, orange. I can do that. Now, to your colleagues, read out the color of the word. Green, red, blue, yellow, blue, black, red, blue, green. Is it a bit harder for people? Maybe you may be able to do both, but this is how we're hardwired. There's certain things that we're able to process quicker than others. So in the world of patient safety, this is absolutely critical. Or how about this? I'm sure you've seen this over your webinar series before, is that if we're able to understand and read English, the English language, we'll be able to read this according to research at Cambridge University. It doesn't matter what order, right? So the ability or the power of the mind, how we're hardwired, absolutely is important about how we go about doing designing safety, as well as reducing risk within our systems. Very quickly, again, another fun test. I can see some people in the auditorium. Give me a thumbs up and point at your finger. I can see some doing it. Okay, now switch that. Are you able to do that? Watch your colleague beside you. It's actually quite fun. Can you do this? Anyone do that? Well, the thumb challenge. So yeah, look at you. Yeah, great job, Dr. Kapoor. See, some people can do that. I'm not very good at it, right? So it's bimanual interference. The way that we're actually hardwired is providing a bit of interference of how we're able to do that. You think it'd be easy, thumbs up, point, right? Sometimes it's challenging. All right, so where am I going with all of these cognitive tests and understanding around how we're designing system safety? Can you tell me, is there something different within this picture? Is one different than the others? Do they look different? Do they sound the same? Yeah, absolutely. This is all absolutely, yeah. They're all local anesthetics. One is a different strength. So if you're looking at the top, as a human, this system design is telling me that these are the same. So light blue in my mind, I see light blue for the first and the third one. They're absolutely different, right? So somehow either the caps got mixed up, or intentionally it was designed differently. But you can see that the strengths are different, right? So the sound like medications have been communicated for decades now. We continue to see how we interact with our world absolutely can be around safety. So even though we try, we still have these systems for concern. what you can see here, so this is a commerce site, a person-to-person commerce site in North America. This is selling scented candles that look like narcotics and other controlled substances. I'm not sure why you would want this, but apparently it smells like pumpkin or fall colors, so that's great. Maybe that's why. Why I'm showing you this, though, is more important around, are your systems adaptable? So, for example, what happened here, this was released by ISQua US, so the Institute for Safe Medication Practices in the United States. The barcode is actually able to open the system, so it wasn't closed loop, right? So what we designed for to be closed loop, meaning that you needed the barcode to the patient, was actually able to attribute to drug diversion. So even though we think we're designing our systems to be safe, are our systems safe going forward? Are they safe today? Are they safe tomorrow? I won't go into too much detail of this due to time, but again, some really great work here, probably in other parts of the world as well that I'm speaking to today. Drug diversion is also an issue in Canada. It absolutely is one. There's some great researchers by the name of Dr. Patricia Turbovich and her team with ISQua Canada designed a pan-Canadian drug diversion tool that is absolutely based on system factors, which may be of interest to the group here today from a practical lens. Okay, I promise that I'm getting very close to being done. So again, we talked about the concept of interconnection. We talked about that humans make mistakes and that we don't like to talk about it. We work in a dangerous industry. We talked about that it is possible to design for safety. It is possible to design for humans. And why is that it's so important to integrated risk management? I wanted to close out this talk a bit about the practical sense. So again, I'm a very practical thinker. If you read any quality improvement paper or safety paper, they're all wonderful. At the end, you usually see a line by saying, future research is needed and go do quality improvement. So think about that, go do quality improvement. Okay, cool. Action is the hardest part of all of this. We can understand from a theoretical lens of how humans make mistakes, how we can design for humans, and how we can ensure that we identify, assess, prevent, transfer, and mitigate risk. We understand that from a theoretical lens. Going out to the feet in the street and doing it is absolutely the critical hard piece to this. So action. I wanted to show you one slide that is at more of a theoretical level, but I'm going to bring it to a practical level. What you're seeing here is the concept of how do you go about doing intentional design for research. So we do research all the time in healthcare, which I think is what makes us so great. But how do you make sure that we're doing this intentionally and practically? How are you bringing this back to the front line or feet in the street? I wanted to show you again from my lens where I see coast to coast in Canada that we are able to do. So not to self-promote, we are also a not-for-profit. This is from a Canadian lens. At the top, you can go and gain any resource. It's absolutely like CAHO and ISQua. This is meant to be sharing. We're stronger together. On our website, you may find a few things that I talked about today that may be of interest. So again, as Dr. Kapoor mentioned, it's very intimidating to have to speak about enterprise or integrated risk management in 40 minutes. What I focused on today was system level points of difference, which may build to your toolkit. Other areas from a very practical sense to build your toolkit may be within some of these resources. So one, the top healthcare risk report, which I showed you at very high level. So this is around in Canada, what are boards of directors of healthcare organizations as well as senior management teams talking about? So this is giving you a sense of what people are talking about. Okay. The second resource is built based on medical legal claims. Medical legal claims are very important in the senses that they happened. We can't do anything about what has happened, but we absolutely can learn from them, right? So we can learn from them and we can intentionally design our systems to mitigate that. From a risk governance standpoint, which is a large part of integrated risk management, there's a tool here called 21 Questions to Ask. this is something that boards of governors, as well as hospital leaders and others, and even clinicians may find value in looking into. For our clinical colleagues on the call today, our risk reference sheets, again, take our learnings from our 40,000 plus claims over the years and builds that into what system factors or what factors can we take away from those learnings. So again, you might say that that example of induction or augmentation, pharmacological induction or augmentation of labor that I spoke to around use of synthetic hormone oxytocin, you might say, okay, is there any practical senses I can take it around induction or augmentation of labor? Absolutely. If you're wanting to look for what we have learned from a Canadian context and from those learnings, you can plug that into the site and pull it out. From a very learner-centric kind of point of view, I know that CAHO and ISQua does a great job, and we've had past webinars on this, but you may find a good refresher around what's the integration or alignment between risk management, patient safety, and overall quality. I know that's a mission of your organization. How does this build in with risk management? What does it go to just culture? So again, we talked about humans make mistakes. We don't always like to talk about it. How do we make sure that we create that environment where people want to share and we create that learning systems of organizations? Another emerging trend that I did a bit of research on before coming in today potentially could be these ideas of historical sexual assaults or allegations of sexual assaults. Specifically from our understanding of our colleagues in the United States, from an integrated risk management perspective, these can be extremely difficult and complex to manage. They can also be extremely costly to defend. This isn't about defending, it's also about how do you learn from it. We created a few years ago something called the Allegations of Sexual Assault Incident Response Toolkit. It may be of some interest. We always don't talk about these things, much like death by suicide under care. And why I bring that up today is that these are all topics from a practical sense that you may be able to take away from this. All right, so this is my last slide. Again, I wanted to close by first thanking all of you for your attention. CAHO, thank you for this opportunity. ISQua for putting my name forward. Dr. Agarwal, Dr. Joseph, Dr. Kapoor, thank you again for the opportunity. Where I want to leave you from a very practical sense is, again, the conversation around is our care safe today? Is our care safe tomorrow? Integrated or enterprise risk management is different in healthcare. It's focused around care. Absolutely, that is important, and we need to be there. When we think about care, we think about humans. Again, we work in a dangerous industry. As humans, we make mistakes. We don't always like to talk about those mistakes. Arguably, error is inescapable, meaning that we know that there will be some degree of error. How do we go about managing those effects of uncertainty? Much like, what do we choose to eat in the day? What do we consume? Where do we walk? What do we do? From this chat, I'm hoping you would take away one thing, is that idea around interconnection. Our toolbox of risk management or integrated risk management is not confined to one theory, one approach, one framework. Where we see emerging is around the ideas that we absolutely work in a socio-technical complex system. And I would argue to say, hey, this isn't rocket science, right? This isn't. This is actually a lot harder. We know how to do rocket science. We don't know how to do patient safety well. Finally, I'll close by saying that safety and integrated risk management, it is a system problem, absolutely is a system problem. And again, if you take away that piece around, it's about doing, okay? So action is absolutely critical. So I'll pause there and I'll turn it back over to CAHO and Dr. Kapoor. But again, thank you all for your attention and welcome all comments and conversations. Thank you again.
Thank you, Trevor, for an excellent talk. As I said earlier, that it's not such a small topic that you can cover in 40 minutes. And basically, in our country, maybe Canada is different, but India is different, absolutely. And here, basically, we have all the SOPs in all the healthcare centers. I'm very sure about it. And with now these procedures of NABH, NABL, and CAHO, together we are working for quality care in the healthcare sector. Still, people do err. And when they err, then to err is human, they say. And but then mistakes are there. And it is not a manufacturing industry actually, where you can have a standard process that cars are assembled like this, you put the wheel and the car is out. Here, a lot of things is basically a clinical assessment or a judgment. It may be by a nurse or it may be by a doctor. So that is where when you use your brains, or let us say you make some clinical judgment, you're bound to make mistakes. But still, what I'm trying to say that there are certain golden rules of, basically this ERM in healthcare management. And the first, what I can give my inputs, what we are doing in our organization, especially in our quality department, is that, we provide some employee education. You see, hammering education on a regular basis is important because everybody comes from diverse backgrounds and from different fields of life and from different, basically different cities and from different families. So their thought process is different. So you basically have to basically provide employee education. Now, this is where, we all CAHO comes into the picture, that we are trying to educate everybody down the line by various webinars and seminars that we keep holding maybe every week or every third day. There's a kind of activity that Dr. Agarwal and Dr. Lallu are doing at CAHO, and we're all part of it. Ultimately, what is not, we have to foster reporting culture. That's very important. There has to be a reporting culture because, what is happening, you can't let people, work on their own de novo, that you do whatever you want and there's no reporting culture. So a training, a reporting culture, and then what we normally think is that, basically promote transparency. It's very important to promote transparency. Most of the organizations, like now the corporate sector in healthcare has developed in a big way, where transparency is very important with private equity investment coming in. But still, in a lot of institutions and healthcare centers, the transparency is not there, and that is where the employee gets confused. You can have one set of rules, you can have one set of SOPs. So basically, let us say employee education, then basically reporting culture, transparency, and ensure a clear departmental communication. We lack in communication of clear departmental communications are not there. Most of the times they are on the whims and fancies of one particular person. And then again, anybody can be running the show, but you have to, win the leadership of the people that you work with. Basically, people are assets, I always say. So then their leadership, has to be won by the people before they start following you. So basically, what I'm trying to say that we have to have a clear standardized process, a training, reporting culture, transparency, and basically assessments and monitoring has to be done. Prioritize. We have to prioritize our actions also. So basically, what I can say that, basically, like you said, look alike and think alike, and those drugs are there. I have seen that maybe last 10, 12 years of our working over here, NABH and NABL, they brought a lot of quality process into the system. Now people think quality, and that is what we are going to now, that we have to make them people think more quality and quality and quality, so that our mission is there that everybody in the country is offering quality care, quality healthcare, at least to the extent of 70 to 80% that we really want. If that is done, we are winners. Again, there's always people can make a mistake, even surgeons make a mistake, doctors make a mistake. And, gradually what is happening that I think our people in this country will appreciate that with more and more super specialties coming in, more and more, everybody's field is so tubular actually, and a holistic view is, going out to the picture day by day. But again, as I said, that there's no perfect system and there is no perfect process. We can try our best to see that, patients are not subject to risk, and we have to mitigate that how risk and management can be done. That's my perception and my summary of the whole issue, although I can talk hours on this. Again, we have certain questions and answers from the public and from the people. Now, Dr. Shaikh Pantamesh Pachmia he says, what is the difference between risk management plan and risk registry in hospital and healthcare organization? Is it necessary for the hospital to prepare and implement both risk management plan and risk registry? If so, for how many years? Any guesses?
Yeah, thank you for that. I can start the conversation and welcome all. So the question, as I heard it, is the difference between the risk management plan and the risk registry. So again, as Dr. Kapoor was saying, this is very complex, and there's lots of tools you can use. Both a risk register and a risk management plan, in my observations, are tools. The risk management plan is usually a strategic overview or a positioning of how that organization will action risk or action safety. As part of that risk management plan can and should be the risk registry. So for example, there is operational risk, meaning everything that you're managing today. And then within that, you'll find that there's usually top risks. And those top risks are top risks for a reason, is that they have been identified as very impactful and very frequent events, and ones that you have specifically chosen to action through your risk management plan. So for example, some organizations may have a certain clinical clinical patient safety incident that is happening, and part of their risk management plan or their top risk would be to reduce that by this. Some institutions may have a focus on business operations, such as cyber-related incidents, and how do you decrease that? Why I'm bringing this up is the risk management plan. If you think about anything, it should be about movement. It should be about action. Your risk management plan, if I have what I see in healthcare, and at least in my experiences, on risk management plans, you may have 50 to 5,000 different risks. That's not always helpful. Yes, we should be ensuring that we're monitoring and measuring, but we should focus on probably 5 to 10 of those, right? We should really focus and try to move forward. That risk management plan should go forward. That risk management plan is tracked by your risk registry. So together they can be separate, but they can also be aligned. So I hope that has shared a little bit. So what I take away from it, multiple tools within your toolbox, both are very good. But again, if you take away anything, it's about action. So thank you.
Thank you, Trevor. Dr. Abhishek Banerjee has a couple of questions, what is the biggest problem in risk management is question number 1. Number 2 is what are some challenges of risk and quality management in hospitals? And number 3 is any example of risk analysis in healthcare related to hand hygiene practices, cleaning protocols. I think they are very, very common questions, and I think Trevor, you would be happy to answer them actually. And
yeah, thank you. So just to reiterate what I heard, so the biggest problem in risk management. Wow, that's a very good question. I'm going to narrow that question a bit. How about and please tell me if I'm not answering correctly, or if you're looking for a different answer. The biggest challenge in risk management sometimes is what you don't know. So unknown unknowns. So who would have thought we would have been, and this kind of goes to your third question around infection prevention and control. Who would have thought that we would be in a global pandemic? Or how would we go about managing that risk? A lot of us wouldn't have guessed that. We just wouldn't. Or how about the frequency and the impact of catastrophic events such as wildland fires or floods? Very, very, very prudent pieces. I'm going to narrow that first question around biggest problem or biggest challenge or opportunity within risk management. In Canada, from where I sit systematically across the coast, I can tell you that moms and babies continue to be an area of higher risk related to moms and babies. An emerging conversation around death by suicide or attempted death by suicide while under care is an emerging conversation. So this is the concept where an individual is unwell, seeking care within our facilities, and is able to harm themselves. And another area that it's not emerging, it's here. We've been talking about it for 2 decades, is the concept around deterioration, clinical deterioration. And this happens across all settings. So the concept of, hey, something happened. Did I notice that happened? And most importantly, or equally important, did I do something about it? So those are the 3 tops. So moms and babies, again, very broad category, death by suicide or attempted death by suicide under care, and then clinical deterioration. Specifically, your last question around risk analysis around infection prevention and control, if I'm understanding it. Absolutely, I would love to connect separately. I would have to have a better understanding of what you're looking for. But absolutely, there's a lot of great work. It wasn't just because of the pandemic, but boy, did the pandemic amplify our understanding around this area.
I just would like to add over here, in the Indian scenario, what we see, the major challenges what we are facing is not reporting. It's under-reporting. That's the thing which is happening, because people do not report, and then what has happened, we may not be able to take appropriate corrective as well as the preventive action. That's the main thing. And our standard accreditation requirement is also there. Once in a year, we have to review the risk assessment. At the same time, you should not wait for 1 year. After every monthly facility around, whatever you come across, and you have to see that those things are also addressed then and there.
Yeah, very, very helpful. Thank you. Yeah, it kind of goes back to that fundamental question of, hey, we're human. We work in a dangerous industry and we don't like to talk about it, right? Like you're absolutely right. And how do we build that culture? I know that reporting culture does signify good safety culture, right? So being able to speak up, comfortable to speak up and share. You're right. How do we get there? We're still learning. And then you add on that safe system design of how do we ensure that we're designing safety on top of that, which we're learning from harm. So you're right on that. Absolutely. Yeah. Great insight. Thank you.
And again, Abhishek has asked that what is the best method of management in forest management? Abhishek, actually, it is not easy to answer in a single line that what is the best system of, doing this, because you learn by practice and you learn as you do them and learn as you make the mistakes. So it takes a long time before you can really have a set procedure. But again, if the guidelines are clear, I'm sure that the errors will go down gradually. They'll never be eliminated, rest assured. But yes, they can go down to a large extent if we have a reporting culture. Madam Gracie said a reporting culture is very important, and fostering, basically fostering teamwork is very important for people to understand that, yes, I'll not be reprimanded. If I make a mistake, I'll be honest about it. And then when I'm honest about it, then I'll not be reprimanded. Rather, somebody will tell me, no, don't do this next time. We have fear of reporting is there that I'll be penalized. That is where we have to take an action, that, you don't penalize people if they make a mistake and they're honest about it.
Thank you. Thank you.
I can just also just pitch in. I'll just take Madam Gracie's comment a step forward, that every month and every department needs to meet, every function needs to meet to look at whatever is happening within their department, not only. So the enterprise has to be broken down. Otherwise, you are going to miss many, many events which are happening in the nook and corner of your hospitals. If you want to capture them, have a monthly meeting of every department and every function. And as a team, they need to meet to see and appreciate the problems that have happened and anticipate the risk. So I think anyway, we are now exceeding time. Over to Lallu to kind of take it conclude.
It's been a very, very vibrant session, very interesting and well moderated. Thank you so much, Dr. Agarwal and Madam Mathai, for adding on your comments as well. Well moderated, well spoken. Trevor, excellent feedback received. You may want to go through the chat boxes to see the good feedback that you have received for the informative session. And dear participants, you will receive your certificate in the next few weeks. It will be uploaded and an email will be sent to you. And Trevor, I would like to request if you may want to share the PowerPoint presentation with the attendees. There are questions regarding that. Are you okay for us to? Thank you. Thank you so much.
Of course. Thank you.
Thanks a lot. And dear participants, you will receive the presentation as well. And this webinar series will also be uploaded in our YouTube channel. So now, without taking much time, let me request Madam Gracie Mathai to hand over the certificate to Trevor for the wonderful job. And it's a very small token of our appreciation to you, Trevor. Over to you, Madam.
Oh, it's really my privilege. The talk was excellent and you have covered everything, whatever we required. And specifically, even the point of view when concerned to every country, not only the Canada, even the outside part also you have covered. Then on behalf of our CAHO, I just would like to hand over this certificate to you. Please accept this.
Absolutely. My absolute pleasure. Thank you so much again for this opportunity.
Thank you. Thank you so much, Trevor. This certificate will be emailed to you along with the feedback that we have received. Thank you so much, dear friends, for joining us from all over the globe. It's been a wonderful, informative session. Thank you, Trevor, for taking your time very early in the morning, 5:30 a.m., to be with us and for such a enlightening, excellent session. And thank you, all of you from CAHO hospitals across the globe, patient safety enthusiasts. Thank you so much for joining us. You make this organization thrive. Thanks once again. Have a great evening.